In this video, I'm going to briefly chat about postural orthostatic tachycardia syndrome, or POTS, and orthostatic intolerance. So POTS is a chronic and disabling condition that is characterised by intolerance of the upright position, also called orthostatic intolerance, where there is an excessive increase in the heart rate without any change in your blood pressure. Sometimes you can have orthostatic intolerance which doesn't reach diagnostic criteria for POTS, but the symptoms are very similar. In order to fully explain what happens in POTS, I'm going to briefly explain what happens when you stand up. So when you go from the sitting or the lying down position to standing up, blood will immediately pool below the diaphragm. So it will go down into the circulation in your legs and in your abdomen. And then what happens is that your autonomic nervous system recognises that you have now stood up. So it does a number of things in order to maintain you in the upright position. So it'll constrict blood vessels in your legs and in your abdominal circulation that will push blood back up to the heart, and it will also increase your heart rate. Now these are things that you won't necessarily know are happening. However, in the situation where you jump up quickly and get that slight moment of lightheadedness, you're simply feeling that compensation happening. When patients experience symptoms of POTS, they will often describe a preceding viral illness, and there is a link between viral illnesses and the onset of POTS. However, sometimes that link won't actually be there, and they won't be able to identify any particular trigger for the symptoms. The symptoms of POTS are many, and misdiagnosis is quite common. The symptoms are really divided into those that are consistent with orthostatic intolerance, and then there can be other symptoms as well. The typical symptoms of orthostatic intolerance are lightheadedness and dizziness when you're standing up, a feeling of palpitations. Some people get headaches when they stand up. Some people get a lot of fatigue that particularly comes on when they stand up in the upright position. Fainting doesn't tend to happen very frequently in POTS, but it can happen. But the feeling of fainting, or what we would call presyncopal symptoms, can happen. There are many other symptoms that can happen in POTS that are considered to be non-orthostatic symptoms, and it is important to distinguish between symptoms that are orthostatic and non-orthostatic, because as I'll explain in later videos on the medications that are used to treat POTS, some of the non-orthostatic symptoms may be less likely to respond to the medication than the orthostatic symptoms. So other kind of typical symptoms that occur with POTS and will be considered more like coexisting or comorbid with POTS, as opposed to being part of the underlying pathophysiology or the underlying physiology of POTS, will be things like fatigue throughout the day, cognitive problems, brain fog. Sometimes there can be gastrointestinal symptoms, and a lot of those symptoms will not actually change enormously based on the position that you're in. So when it does come to the diagnosis of POTS, there are some diagnostic criteria that are recognised. So if you do either a tilt test or an active stand test, there should be an increase in the heart rate of greater than 30 beats per minute that should be sustained within 10 minutes of assuming either the tilt or the upright position. The blood pressure needs to remain stable, and the symptoms should be present for approximately 3 months before the diagnosis is actually made. In addition, it should be ruled out other causes of having a fast heart rate, such as fever, pain, being on medication, that can actually lead to an increased heart rate that you mightn't have thought of. Something like anemia can often lead to an increased heart rate, so those conditions also need to be ruled out. When it comes to characterising POTS for patients, there are some subtypes that are described in the literature, and I'll explain what they are just for the purposes of giving an explanation, but I should point out that it unfortunately isn't quite as simple as your symptoms are A, B and C, therefore you fit into this particular category. There does seem to be a bit of an overlap between the categories. So there's what's described as hyperadrenergic POTS, neuropathic POTS, POTS related to hypovolaemia, and POTS related to deconditioning. Now there are two other conditions that I'll describe briefly in a separate video. One would be POTS in relation to the hypermobile version of Ehlers-Danlos syndrome, and POTS related to mast cell activation syndrome, but I won't discuss those ones in this video. So when it comes to hyperadrenergic POTS, the underlying pathophysiology is thought to be raised neurotransmitters that activate the sympathetic nervous system. So when patients are felt to be suffering from this variant of POTS, they have all the typical symptoms of POTS, but they may also describe more anxiety, tremulousness, insomnia tends to be a more prominent symptom of this variant. And sometimes patients may respond better to beta blockers if it's felt that a lot of their symptoms sound hyperadrenergic in nature. The second kind is neuropathic POTS. So here it is felt that the nerves in the lower extremities, mainly like the feet and up to the shin level, aren't working properly. So the small fibres aren't working properly, and that is leading to the blood vessels not being able to constrict enough to push blood back up to the heart. So that is considered another potential underlying cause of POTS. There's POTS related to hypovolaemia, meaning that if you have a lower blood volume, that your system is just not well placed to keep you upright, and that you will have more of a tendency to having an excessive heart rate in order to keep you upright. And then there is POTS associated with deconditioning. Now, for the most part, deconditioning forms part of the condition as time goes on, because as patients with POTS will well understand, it's very hard to be active when you have symptoms that are so prominent when you're upright, and then you can become deconditioned. But sometimes it's felt that deconditioning can be a cause of it. And for younger patients, this can be quite confusing, because it's one thing if you had like a prolonged surgery or prolonged period of bed rest, and deconditioning is easier to understand. But if you were otherwise fit and healthy and then you develop POTS, it's harder to think, well, how could you be deconditioned because you've been so active? So the latest thinking on that is that it's not so much that you've become deconditioned, but more that your physiology was just similar to that of a deconditioned person, and the main physiology of that is actually a smaller heart and a smaller blood volume. So you are in a way just maybe predisposed to developing POTS, as opposed to the deconditioning leading to the POTS. The last thing I'll say in this video is that oftentimes patients who have POTS or who are felt to have symptoms like POTS won't reach diagnostic criteria on the TILT test. And this can be another source of confusion, and can sometimes actually be quite disappointing for patients, because they've put a lot of thought into the fact that they have POTS, and then they're kind of holding out for the test saying this will tell me that I do have it, and it's kind of like trying to get a validation for their symptoms, which they shouldn't need anyway, because if you have symptoms, you have your symptoms. So sometimes you will not reach the diagnostic criteria, meaning that the heart rate won't increase by the significant amount when you assume the upright position. But there's two things I'll say about this. Firstly, the TILT test is very useful anyway, because I have found in my clinical practice that you can see a lot of kind of sensitivity of the autonomic nervous system throughout the TILT test, where the patient's blood pressure and heart rate are actually fluctuating quite a lot, but they're not necessarily reaching the criteria for POTS. So that's the first thing. But the second thing is, what's more important, and more important than any clinical test, is having an in-depth clinical evaluation by someone who understands autonomic disorders. Because even if you don't reach criteria for POTS, it doesn't mean you won't respond to the lifestyle modifications. It won't mean that you don't need the exact same exercise program as a patient who does meet the criteria for POTS needs. And also, there may be some medication that you might respond to, but that should only be given to you by someone who understands the autonomic nervous system and has done an in-depth evaluation of your symptoms, and also who's going to follow you up in a clinical sense to see how you're getting on with the medication. So that's just a brief overview of POTS. I hope it's of use to those of you who are suffering from POTS and orthostatic intolerance, and there's a huge overlap with the long COVID symptoms as well. And I'll be doing more videos to explain the different medications and lots of different things about POTS and orthostatic intolerance going forward.